Hey, thanks for tuning in and checking out this video. Don't forget to like and subscribe. All of these cases are practice cases, and I made this presentation just for fun to go over some pancreas pathology. So, hope you enjoy it.
I chosen this special background, and the reason I chose this special background art piece will be revealed at the end of the presentation. If you are an art buff and you know this painting, congratulations. I'm not an art buff by any means, but this is a really cool painting. Okay, so let me go to Arrow. So in this presentation, I will briefly go over how I read slides, or at least what I've learned so far that it's been working for me. Briefly touch upon the WHO criteria for GI, and then we'll go through 6 pancreatic disease cases. So the way that I approach my slides when I read slides is that the first thing I want to know is the tissue source and specimen sampling method. It could be a biopsy, resection. Sometimes it'll be autopsy tissue. It's important because the clinical context, tissue quality, all of these things affect diagnostic sensitivity and specificity and positive and negative predictive value. Pathology has adequacy criteria established for some specimen types. For surgical pathology, there's kind of an adequacy criteria. Usually that's the staging criteria. That's the surrogate adequacy criteria. In cytopathology, there's a very strict adequacy criteria for each sampling, and you have to be aware of processing and handling artifacts. So tumor staging that's put out by the AJCC and also by the CAP, they make staging guides, is very important in pathology because all tumors get staged in the report, usually. And usually you approach the slide by looking at low power for just a general bird's eye view architecture, and then you go on to high power to look at cytologic detail. For this, I refer you to Chapter 1 of Malavi and also to another lecture that was recorded by Dr. Biden. His lecture is great. You should definitely check it out. And then from this, just looking at the tissue, at least I kind of try to eyeball where that diagnosis is going to end up and what kind of category. Is it going to be benign, variant of benign, or some sort of embryological variant? And it's important to know these because you can get tricked up about these variants, and they will, if you're not sure if it's a variant of benign or some sort of embryological variant, you can mistakenly categorize it as a neoplastic and diagnose cancer, which is very, 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 very bad no-no. Then there's also medical pathology, and there's neoplastic pathology. So medical could be reactive, infectious, autoimmune, metabolic, and toxicologic. And then neoplastic, you start looking at stuff like hypertrophy, hyperplasia, metaplasia, dysplasia, and then whether something is low-grade, high-grade, invasive, or malignant. This is interchangeable. Belisi, here's a PMID if you want to read this. It's a really great article. He talked about having 7 different categories for tumors like carcinoma, sarcoma, lymphoma, melanoma, and then there's these that don't really fit into a category, and then there's like germ cell tumors, mesothelioma, paraganglioma, and pheochrocytoma. After you categorize what kind of tumor you're working with, you're going to want to maybe order some immunohistochemistry molecular studies and then stage it. For the purposes of this presentation, we're going to be in the neoplastic category, and we're going to be dealing with like either low-grade, high-grade invasive lesions, and mostly we're going to be in the carcinoma category. That's where we fit in here. And then usually when you finish your workup, you write the report, and then you'll present a tumor board, call the clinician, notify them to know that they're aware of what's going on with the patient and what the pathology is showing. So in the pancreas, this is just the pancreas. The WHO in 2019 updated their criteria, and they recognized that there's multiple different types of benign, malignant, and neuroendocrine lesions in the pancreas. It's important to know, I didn't say that, but it's important to know that the normal histology of pancreas, because once you know the normal histology of pancreas, a lot of the tumors derive from normal histologic cell types. So for example, the benign epithelial tumors and precursors, they all come from these cell types. So like pancreatic acini, ductal epithelium, and some of the connective tissue that you see around here surrounding the duct. The neuroendocrine neoplasms, they could be functioning or non-functioning, and they usually are derived from cells found in the islets of Langerhans, which are these clusters of cells right here. And you can see they're functioning neuroendocrine tumors because they could secrete any of the hormones shown here. So in this presentation, we're going to cover select cases because they're really nice representative cases, at least in my opinion, my limited opinion. So let's begin with case 1. This is a 60-year-old gentleman. He presents with a 40-pack year smoking history. He presented with, again, a lot of these tumors, what you're going to find, a lot of pancreatic lesions, they present with vague kind of abdominal symptoms because they're very nonspecific, and that's an issue with pancreatic cancers and a type of neoplasm, pancreatic neoplasms, because the symptoms are very nonspecific, and that makes it very hard to diagnose. But this gentleman presented with abdominal pain, increasing intensity, chronicity. He got a CT scan, and it showed like a kind of a poorly enhancing, poorly defined pancreatic mass located in the head of the pancreas. The mass incompletely surrounded the superior mesenteric artery and the celiac artery, so the lesion was deemed resectable. If they surrounded by 180 degrees, the lesion is non-resectable. So the patient underwent pancreaticoduodenectomy, known as the Whipple procedure. Here you could see the lesion right here. It's kind of surrounding some vasculature. Here's looks like a gallbladder. It's very dilated, mostly because of probably the ductal system is obstructed by the lesion. So after the surgeon resected the lesion, we received it, and we were able to gross it, ink it, and you could see that this is an irregular stellate white to yellow pancreatic mass. It's pretty large. It's 3.5 centimeters in the head of the pancreas. Here's the duodenum. Here is likely what we're seeing is a cross section of the ampulla of water right here. So this is the patent duct visible transversing the tumor. I think we're seeing also one right here. Yeah, that's the one right here. And the inking just tells us where the margins are. Inking is very important in pathology. So histology, we got 2 slides for this case. The first slide is we're going to look at adjacent normal pancreas representative section, and 2, we're going to look at the representative section of the lesion. So let's take a look over here. Okay, so this is 1 and 2. This is what we're going to be looking at. So let's zoom out a little bit. And first, this is the adjacent pancreatic tissue, the normal tissue that we submitted with the pancreatic lesion. So right away, this is one of the slides that I use in my normal pancreatic histology talk, and we can see there's adipose tissue in the periphery. There's adipose tissue scattered throughout here. There's fibrous septate surrounding the pancreatic parenchyma right here. We could see some islets of Langerhans, even from this low power. Like, we don't even need to zoom in. From this low power, we can very easily see that there's some islets of Langerhans hanging around. And we could see there's these large ductal structures. And this is very important because these large ductal structures, like, let's take a quick look at what's going on here. But generally, like, we're going to, before we even zoom in, like, take a look. Overall, we don't see any lesions in this pancreatic section that was submitted to us to read over. We're not seeing any discrete lesions. We're just seeing a lot of benign structures. But these ducts do look very interesting. Now, keep in mind, like, a lot of these ducts, there's different types of dysplasia that can occur in the pancreatic epithelium. And here what we're seeing is relatively low-grade dysplasia because the nuclei are all on the basal surface. There's mucin at the apical surface of the duct. So we're going to take a quick look over here and make sure that we're not missing any dysplastic epithelium and any type of carcinomas. But over here, this is probably some sort of low-grade dysplasia that we're seeing. Let's take a look at the other ducts in question. We can take a look over here. Again, generally, oh no, what happened? Let's go back to full screen. Yeah, we could see more ductal structures, but you could appreciate that a lot of the epithelium, the nuclei are very, very orderly. Each cell is respecting each sort of kind of maybe right here they're kind of clumping on top of each other, but generally, like, for pancreatic lesions, for type of dysplastic pancreatic or pancreatic intraepithelial lesion, there's either low grade or high grade, and here we're seeing more of the low grade components. Very orderly, very Nuclei are very on the basal surface. The apical cells are producing mucin. Okay. So let's take a look at our next section that was submitted. And again, from the low power, we could see some large pancreatic kind of tissue on the periphery over here. We're seeing some ducts again over here, adipose tissue, likely a large vessel. Let's get the screen thingy going. But here is what we're seeing. The issue is here. You can take a look. We're seeing a lot of little glands, and they're kind of growing all throughout the tissue, all throughout this dense fibrous stroma. And that is very worrying, because that is likely some sort of adenocarcinoma. Like, for example, like, just look at this area. This is a very worrisome features, because here you're seeing a gland, but here, like, look at these like smaller glands. They're really just kind of growing and invading the stroma. So this is something that would be worrisome for pancreatic adenocarcinoma. And we can keep looking at it more and more, but overall, like, we're seeing a lot of tiny ductal epithelial glands, like, for example, this one over here and this one over here. They're just all kind of invading this fibrous stroma. So that is a big no-no. So let's take a look here. Okay, so we looked at the histology, and what we saw in the first tissue, or in the first slide, is we saw a lot of pancreatic intraepithelial neoplasia. Like we very briefly mentioned it, is that there could be low grade or high grade. It's a two-stage kind of grading criteria. And it's non-invasive pancreatic intraductal proliferation. It's believed to be a precursor of ductal adenocarcinoma. And again, what we saw was pretty low grade, mild to moderate nuclear atypia. High grade, we'll see marked nuclear atypia, loss of polarity. We did not see loss of polarity. All the cells were kind of polar or very, very organized. So this is, in the first slide, we saw some pancreatic intraepithelial neoplasia. Here's some really great pictures. What we were seeing is kind of more along this line. This is what we were seeing is right here. My mistake. So A is showing normal pancreatic duct epithelium. You can see how it's very well organized. B and C are showing low grade intraepithelial neoplasia, because the duct is lined by a single layer of cells. There's abundant mucinous cytoplasm over here, but the nuclei really lack atypia. Here's some like a little higher grade, but still low grade intraepithelial neoplasia, because the lining cells show large hyperchromatic nuclei. You could see, because remember we saw some focal areas like this, like they're kind of stacking on top of each other. They're losing their orientation over here. And here in figure B, we could see that the pancreatic duct is lined by these epithelial cells. The nuclei are very large, and they're really like kind of having these micropapillary architecture, prominent nucleoli. This is more consistent with high grade PANIN. And this could also be, I guess, called carcinoma in situ. This would be very worrisome, and it would be important to look at any invasion or invasive component. So what we also saw is pancreatic ductal adenocarcinoma. It's usually it's an adenocarcinoma that's arising in a pancreatic ductal system. It comprises almost majority of pancreatic neoplasm. There's multiple histologic variants. There's colloid, adenosquamous, clear cell, signet ring, medullary, hepatoid, undifferentiated, and carcinomas with mixed differentiated. Treatment is resection, but the problem is, remember how we mentioned the superior mesenteric and other vascular structures? If the tumor is surrounding those vascular structures, they're not really deemed as resectable. So resection is very limited. So chemotherapy is a pretty mainstay treatment option. Lymph node mets are present at diagnosis or at surgery 70 to 80% of the time. And generally, we'll see like there's a wide differentiation spectrum. Glands grow in haphazard fashion and in a very infiltrative, like we saw in that slide. The glands were just kind of growing all into the stroma. And nuclear features, there's some nuclear crowding, overlapping, loss of polarity, irregular chromatin, irregular. So this is kind of nuclear atypia shown here. So there's different variants of PDAC. Why is it so important to know these variants? Well, they're all, not all of them, but some of them are associated with different prognosis and have clinical implications, like signet ring, extremely poor prognosis. adenosquamous, poorer prognosis than PDAC, medullary, better prognosis than conventional PDAC. So it's important to like recognize this. And undifferentiated carcinoma with osteoclastic giant cells is extremely poor prognosis. So after we see the cells, we see the slide, we diagnose it. As pathologists, we have to sign this case out. We have to write the report. So what does that mean? We have to stage this tumor. In our case, the tumor was greater than 2 centimeters, but less than 4 centimeters in greatest dimension. So that would make it a PT2. We didn't really, because we could assume that it was not metastatic. In reality, they're all metastatic. Majority of them are metastatic. But in our case, we could assume that no lymph nodes were positive. So that's great. And then this is additional features that we saw in our resection. We saw pancreatic intraepithelial neoplasia, and we saw high grade. It's important for adenocarcinomas to grade the nuclei, and we can say that it's moderately differentiated in that section. So we can say that it's a PT2 PNO, and then it has some background high grade pancreatic intraepithelial neoplasia. So we're going to sign this case out. Hypothetically, if this was a case that we received, we would sign this out as pancreaticoduodenectomy. It's invasive ductal carcinoma. It's a grade 2 because it's moderately differentiated, measuring 3.5 centimeters in greatest dimension. We'll comment on the margins. We'll comment on the lymph nodes. We could say that we didn't see any definite lymphovascular perineural invasion. And the background pancreas has low-grade pancreatic intraepithelial neoplasia. We could stage it, and this is the most significant prognostic factor. We would also order immunohistochemistry for this case, but that's kind of just beyond the scope of this talk a little bit. So let's just, let's keep going. Our next case is we received a consult from a colleague, and the history for this patient's a 70-year-old gentleman. Again, abdominal pain, vague symptoms, kind of some jaundice, underwent a CT scan, and found a pancreatic head lesion. They underwent a Whipple procedure, and they resected a relatively large 5-centimeter pancreatic head mass. When they sent the head mass to us, we could see this is like a relatively well-circumscribed lesion. It's large, it's fleshy, it's got this white tan with lobular configuration and easily identifiable necrosis over here. So this is case 2. Let's take a peek at the slide. Let's go over here and see what we see. So it's important to note that right here, like from a low power, we can appreciate that this is likely pancreatic tissue. So we're in the pancreas. This is a surgical resection. We can see that there's some fibrous connective tissue, some piece of tissue right here, and then so let's take a look, zoom in to this area first, because right here, like this is probably our lesion. It's very different. You could see it's very different. So let's take a look over here. So very briefly, let's get this window thingy going. We're looking at, again, normal pancreas, and it's great to have that we have normal pancreatic tissue for comparison. It's really important to have that, or at least it's not necessarily important, but it's just very helpful to have a section of pancreatic tissue or of normal tissue when we're looking at this type of a case. So right away, take a look at this. Wonderful example. Normal pancreas, normal pancreatic acini, and then right here, we're seeing these kind of like cells, right? They're lobules of cells. Oh no, it's doing that thing again. Sorry. These lobules of cells, they are relatively well encapsulated by this fibrous stroma. It almost looks like they're originating from these acini. And oh my God, we can see a mitosis right there. Look at that mitosis. And let's take a look. Let's zoom around. But yeah, like it's pretty. Oh my God, there's tons of mitotic figures. Like look, boom, 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 boom. There's just a lot of mitotic activity. So this, wow, look, I just saw ring mitosis. Yeah. So this tumor is very mitotically active. So it's likely a fast-growing lesion. Like right there. It's everywhere. The cells are have very large nuclei, very monotonous. They're all clumped on top of each other. Oh my God, look at that one right there. And so a lot of mitotic figures, but it's a very monotonous lesion, and it's very kind of homogeneous, very monotonous. And then you could look at the cytoplasm. It's very kind of eosinophilic. the nuclear to cytoplasmic ratio maybe is increased. It's definitely increased for sure. And you could see these nuclear outline. You could see nucleoli. Nucleoli, and it's kind of very clear nuclei. Again, another mitosis right there. So it's a very mitotically active lesion that resembles normal pancreatic tissue. So, what could this be? And it's also an issue because it is pretty invasive. Look at it, like it's growing everywhere. Look at this right here. It's literally growing everywhere. So let's take a look. Okay, so we looked at this lesion. We have an idea of what this could be. So this is an acinar cell carcinoma. It's very rare. It's highly aggressive. It's malignant exocrine carcinoma with acinar differentiation, and it makes sense because it does look like normal pancreatic acini. The survival median is 19 months, 5 years, 25%. It's rare because it's 1 to 2% of pancreatic neoplasms. Usually occurs later in life, between 5th and 7th decades. It's aggressive, microscopic. It's densely cellular with multiple architectural patterns, mostly commonly acinar solid. And again, it has very uniform nuclei with central prominent nucleolus. And that's exactly what we were seeing. We were seeing these kind of salt and pepper nuclei and so on. And the thing is, because the exocrine pancreas secretes all of the digestive enzymes, you could use like digestive immunohistochemistry, and it will stain for these lesions. It will stain for them. Oopsies. So like for this is an example of trypsin, and you can see it's very cytoplasmic staining over here. So for this, we would stage it as well, because the lesion was greater than 4 centimeters, I believe. Yeah, how big was it? It's a 5 centimeter lesion. So greater than 4 centimeters, no lymph node mets, and we didn't see any of this stuff in the background. So we would sign this one out as a pancreas, pancreatical duodenectomy, acinar cell carcinoma, measuring, put up how big it is, comment on the margins, comment on the lymph nodes, see whether there's any perineural or lymphovascular invasion. In this case, we did not see any, and stage it. Great. Let's move on to case 3. Okay, so another consult is received from, I don't know, maybe an institution or maybe a colleague wanting your opinion. And this is a 40-year-old female. She presented with watery diarrhea, hypokalemia, and achlorhydria. This is like essentially like a step 1 question right here. Imaging revealed a mass within the pancreas, and grossly the lesion was 6 centimeters, so it's pretty big, really well circumscribed. Look how well circumscribed it is, and it's white tan and pretty firm. Here's the normal pancreas. Here's a lesion. Very dense, white, firm, circumscribed lesion. Oh no! Oh, I just gave away the answer. But I'm sure that it was a pretty obvious presentation. The watery diarrhea, achlorhydria, hyperkalemia. It's a very, very classic presentation. And so, okay, let's look at it from this low power. We can see that this is likely our pancreatic tissue. I'm not sure if there's any normal pancreas on this slice, but we could see that this is our lesion. Look at it everywhere. Look, it's everywhere. It's pretty invasive. It's a really thick, dense fibrous stroma. So let's do like a quick pan around the lesion, just to get an idea of what we're working with. And then we'll zoom in on a section of the lesion and describe the cytology and the morphology. But again, like look, it's very invasive. It's very invasive lesion. It's important to like look at everything that we see here. But very, very invasive, a very dense, fibrous kind of lesion that we're seeing here. So because it all looks very similar to one each other, let's take a quick look. Let's take a look here. So we're seeing these like lobules, almost these nests of cells, and even from you can appreciate, like I could zoom out even a little bit more, but even from this power, you could appreciate that the cells are very pale. They're very large, and let's just go in a little more. You could see the nucleoli from this power. From such a low power, you could see it. So let's take a quick look inside here. We're seeing these fibrous septa surrounding this lesion. The cells look very kind of maybe a little mixoidy, but very kind of salt and pepper like nuclei. And you could see that really well here. Look, it's very salt and peppery. The nucleoli are very prominent. There's some nuclear clearing. Cytoplasm is very faded and eosinophilic, kind of faded cytoplasm. And if you remember what normal islets of Langerhans look like, these cells look very similar to that. And there's some like capillaries interspersed between them. So I think we have a good idea of what we're working with here. We are working here with a VIPoma. This is a neuroendocrine tumor originating from non-beta cells that produce VIP, leading to increased intestinal secretions like the Woodhull syndrome, watery diarrhea, hypokalemia, and achlorhydria. Yeah, I just want to make sure that I say that right. It's hypokalemia. Okay. And this is also called the Werner-Morrison syndrome. 70 to 90% of these are within the pancreas. Diagnosis confirmed by a high VIP levels. These are super duper rare. And histology, we're seeing like this kind of salt and pepper nuclei, very prominent nucleoli. This is the chromogranin stain. So these lesions, because they're neuroendocrine cells, they stain with chromogranin and synaptophysin. And it's also important for these tumors, because they're neuroendocrine carcinomas, to get the mitotic figures and get the Ki67, because Ki67 helps us, this is the proliferation, the mitotic rate, a surrogate marker for mitosis. It helps us stage these tumors. So for staging neuroendocrine tumors, it's a little bit different. We want to know how big the tumor is and whether it's limited to the pancreas. In our case, it was limited to the pancreas, but it was definitely more than 4 centimeters, and there was no Mets. So for this, we will sign this case out as pancreas, partial pancreatectomy, neuroendocrine tumor, VIPoma, grade 1, because we saw less than 2 mitoses per 2 millimeters. It measures about 6 centimeters. Well, it measures 6 centimeters in greatest dimension. We'll comment on the margins, lymph nodes. We talk about lymphovascular invasion and perineural invasion. We'll stage it, and we can put a little note here, and in a note say, this was positive for VIP, chromogranin, synaptophysin, and Ki67 was less than 2%, so that is concordant with the diagnosis above. Great. Moving right along. So we are at case 4. This is this is an 80-year-old female, and she presents with chronic abdominal pain, undergoes abdominal imaging, and she gets an imaging that shows 5 centimeter mass is seen in her pancreas. The mass is communicating with the main pancreatic duct. That is important because depending on the kind of lesion you have, some lesions will communicate with the pancreatic duct and some will not communicate with the pancreatic duct. So that helps you in your differential diagnosis. And the lesion was aspirated, and the cyst fluid contains a high level of CEA. And here, this is the gross picture. We can see this is the normal pancreas. This is the duct, and this is the mucin that's exuding from the tumor. And this is the axial CT showing that, indeed, the pancreatic duct is dilated. This is case 4. Let's go take a look at what we have for case 4. And this is a beautiful section because for this lesion, we can see that there's normal pancreatic tissue right here. There is some sort of ductal epithelium right over here, like a large duct. There's another duct. There's smaller ducts. And then there's like this like cystic kind of lesion right over here. Very interesting. So let's zoom in. We'll do a little low power pass over this lesion. We can very clearly see that this is normal pancreas. We can see islets of Langerhans, some fibrous stroma, more islets of Langerhans. Here we can see the epithelium. And even from this epithelium, from this power, we can see that the epithelium is pretty abnormal. Like, it's very complex. Ductal epithelium should not be complex. And the reason this is also a beautiful section is because right here, right over here, we could see what normal pancreatic duct epithelium looks like. But then, let's keep tracing this epithelium, and OMG, look at it right over here. We are seeing loss of polarity. Look at that, loss of polarity, some tufting, some kind of papillary-like structures. We're also seeing these like goblet-like cells over here. Like, that is very suspicious. So what's important to note is that this looks like, oh no, it's doing that thing again. Sorry. If we zoom out, like, this looks very, if you were to look at a cross-section or a section of a small bowel or in small intestine, you would notice this, because this has, again, look at that. These are goblet cells. and this epithelium is okay. We've seen some mitotic figures. I'm assuming these could be mitotic figures, but I'm assuming they're okay because they're in a basal area of the cells, or the basal location of the cells. But what is worrying me about some of these lesions is it's getting complex over here, over here, over here. So this is a lesion. This is likely an IPMN, intraductal papillary mucinous IPMN neoplasm. And what's important for these is that we want to. There's different subtypes of these. I believe there's gastric, intestinal, and pancreatobiliary. For this case, this is very likely the intestinal subtype. And then when you look at these, you want to look at several things. You want to be able to categorize it. So what kind of epithelium it has is what type of category it gets. In this case, the epithelium looks like small intestines. This would be likely the intestinal type. You also want to look very carefully through these lesions, and you want to look for two things. You want to look for any dysplasia. So like stuff like this is very worrying because you could see that this is like, maybe this would be a nice example. Right here, this is kind of like low-grade dysplasia because the cells are tall, they're columnar. But then over here, we come over here and we're seeing maybe not so much high-grade dysplasia because the nuclei are not getting cleared. They're not like so much growing on top of each other, but it is more worrying to me because these nuclei are kind of like stacking on top of each other a little bit. So for these lesions, you want to look for whether there's any low-grade or high-grade dysplasia. And then if there's high-grade dysplasia, you want to look for any invasion. You want to look for small glands that are invading into the stroma. The reason is because all these things that you see, like high-grade dysplasia or invasion into the stroma, will significantly affect patient outcome. So it's important to find them because if this lesion is invasive, it will significantly reduce the patient outcome. So it's important not to miss that. So let's take a look. What do we have here? So we have intraductal papillary mucinous neoplasm, also known as the IPMN. It is a mucin-producing epithelial neoplasm. It's present within the main duct, or it could be present within the branches. It is a pretty common neoplasm. It's found in 20 to 50% of resected cystic pancreatic tumors. The average age is 60, but it occurs in this range. Again, it's typically asymptomatic. You could have some low-grade pancreatitis as a symptom. It could be detected as a incidental finding. It has better prognosis than PDAC, but it may contain focal invasive components. That is very, very important. So in the histologic exam, it's important to look at what type of epithelium do we have. Is it high grade or low grade? In our case, it looked generally very low grade. We want to determine the subtype. Is it gastric, intestinal, pancreatobiliary, or oncocytic? The reason is because different subtypes have different findings associated with them that we want to look for. Normally, the gastric subtype, I'll talk about that in the next slide. And we want to see if there's invasion. 35% of main duct and 15% of branch duct IPMNs have invasive components, so it's important not to miss that. So, like we said, we want to look for dysplasia, yes or no, or low or high. So for low-grade dysplasia, and this is what we were really seeing. Take a look at that. This is exactly what we were seeing. Columnar cells with basally oriented small nuclei hanging out at the bottom over here, and these are typical of low-grade dysplasia. High-grade dysplasia looks like this. It's micropapillary intraductal proliferation of tumor cells, very high anti-C nuclear to chromatin ratio, scattered mitoses are present. We did see mitoses, but they were in a basal layer, so I'm not sure exactly how to qualify that, but to me, like, it looked pretty low-grade. And this is another example. This is a main duct IPMN of pancreatobiliary type. Look how complex this proliferative epithelium looks like, and we are seeing a lot of high-grade dysplasia. There's multiple types. There's 4 types of IPMN. So we're gonna talk about 3 types over here. We saw a lot of these ones over here. So we saw a lot of interstitial type. We saw some nuclear pseudostratification, bunch of goblet cells. And the importance, because these can have foci of high-grade dysplasia. And that changes the prognosis to some extent. We can also have gastric type, which looks like this, looks like here. It has no goblet cells, but we saw goblet cells, so ours was more intestinal type. And it has like more like a low-grade mucinous epithelium, abundant apical cytoplasm, mucin, lots of mucin. Looks like kind of foveolar epithelium in the stomach. And histologically, it's low-grade. So if we see like an IPMN with this type of pattern, we'd be like, okay, well, it's gastric, likely low-grade. That probably has a better prognosis. But if we're going to see it with intestinal pattern, and we're like, okay, oh my God, we really need to look super duper hard, maybe twice as hard, to see if this has any high-grade dysplasia. There's also the pancreatobiliary type, which is characterized by these kind of like these long, thin, branching complex papillae with moderate amphiphilic cytoplasm, has these round, like vesicular nuclei, and this kind of degree, this kind of architecture indicates that it has high-grade dysplasia. If we see that our IPMN is of this subtype, we would likely be able to find some high-grade dysplasia because the pancreatobiliary type is associated with high-grade dysplasia very frequently. So how will we sign this out? We'd sign this out as an IPMN, comment on low-grade intestinal epithelium, talk about the size in greatest dimensions, comment on the margins, comment on the lymph nodes, and say like, there's no definite lymphovascular perineural invasion present. Staging for IPMN is interesting because it's based on whether the lesion is high grade, then it becomes a carcinoma in situ. In our case, the lesion was low grade. So it's not a carcinoma in situ, so that is really good news for the patient. But if it's a carcinoma in situ and if there's an invasive component, then we would have to stage the lesion. So IPMN with invasive adenocarcinoma component. IPMNs without an invasive carcinoma component are curable. 5-year survival for low-grade IPMNs is like 100%. That's very good. High-grade IPMNs is 85 to 90. These are amazing survival rates. But if there's an invasive component, it's likely pancreatic adenocarcinoma, and the survival drops significantly. So it's very important to look at this lesion very, 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 very hard and see if there's any invasive component present. So let's move on to case 5. This is a 66-year-old male, presents with a 4-centimeter incidentally discovered pancreatic head mass. So, okay, the surgeon resects this lesion for us. We receive it in the gross room, and we are looking at it, and we're like, okay, well, here's normal pancreas, and here is our lesion right here. It's very well circumscribed. You can see this tiny, thin little capsule with complex, thin, smooth, kind of walled cysts everywhere. And the cysts, it looks like they don't really communicate with the pancreatic duct so much. Then we have the CT scan. We can see that it's a well-defined enhancing mass in the pancreatic head. We're seeing some calcification and a hypodense center over here. I'm gonna go to path presenter and see what we got for case number 5. Again, wonderful section, and the reason why it's a wonderful section is that we could see that there's normal pancreas over here, so we have a very nice comparison, and we could see our lesion is right over here. Even from low power, we can very easily appreciate it. We'll see some hemorrhage and some vascular structures, but yeah, generally this is our lesion. Let's take a look at it. Because we'll do a low pass over it really quickly, just to see what it looks like. Okay, and you could appreciate that it's very cystic. Look how cystic it is. Okay. Very cystic lesion. So in pathology, if you have a cystic lesion, it's very important to look at the epithelium that is inside or lining the cyst, because that will very often help you decide whether this lesion is high grade or low grade or what kind of lesion it is. So let's take a closer zoom around over here and see what kind of cells do we have. What we're seeing so far, like we're seeing these kind of papillary, like vascular, some microvascular, maybe some capillaries running through these cores. Yep, some capillaries, blood vessel structures. But generally, like, remember how we saw like high grade dysplastic nuclei in an IPMN in the case before. Here, what we're seeing is these very it doesn't look like cilia. No. What we're seeing is like these cysts lined by very small kind of epithelial lining. And I'm not sure if I'm like hallucinating maybe or not, but these look like cilia. Like right here, these look like tiny little cilia. I don't know. Maybe I'm just seeing things, or that's the secretions kind of piling up on them. But they look like very kind of cleared cell lesion, very benign, very nuclear. The nuclei are very well organized. We're not seeing mitotic activity. We're not seeing high-grade nuclear features. We can even compare the sizes of these nuclei to like maybe if we see like a lymphocyte, that will help us to get a rough estimate of how big the nuclei are. Another good idea to do is to look when we're looking at nuclear size. Here's a good example. Take a look at these cells lining the cyst and take a look at the cells or the nuclei of the benign normal pancreatic acini. They're roughly the same size. So right away we're thinking a cystic lesion, or at least we're looking at it like at a cystic lesion with relatively benign features. So again, we're in the like if we were to go like to categorize this, we'll be like in a neoplastic category. Then we'll go into the benign category, and this is likely something that's a low grade lesion. So this could be, I think it's a mucinous lesion. Let's take a look exactly what this could be. So path presenter case 5. Oh, I'm sorry, it's a serous lesion. I was thinking of something else. So this is a serous cystadenoma, and as you saw as we were zooming around the slide, it's a benign entity. In a most typical presentation, it's composed of multiple microcysts lined by bland cuboidal-like epithelium. The lining cells have usually pale cytoplasm, is kind of exactly what we saw, and have congested capillaries adjacent to the papillary epithelium. And again, small pertinacious secretions is found in the lumen, and at a higher magnifications, it's very characteristic of we're seeing some capillaries and very kind of benign lining epithelium. So this is a serous cystadenoma. This could also be a serous cyst adenocarcinoma only if this lesion metastasizes beyond the pancreas, and that is very extremely rare. These are serous cystadenomas are very benign lesions. And again, like let's take a look at it again. This is exactly what we're seeing. Look how textbook this is. It's a serous cystadenoma, cysts lined with fluid. Cysts with proteinaceous secretions, lined by these very unremarkable kind of not very doesn't have a lot of atypical, but various small cells lining these cysts. Nuclei are very benign looking. There's no atypia. They're very eosinophilic, kind of have some clear nuclear clearing, and we have all this collagenous stroma. We have all these vasculature right around the cystic area. So this is textbook presentation for serous cystadenoma. There's solid variant and microcystic and oligocystic variants, but generally these are variable size cysts lined by single layer cuboidal flat epithelium. They lack atypia. It's exactly what we saw. We didn't see any atypia, and we saw no mitotic activity. And we saw a very rich capillary network mixed with the epithelium. So that brings us to our sign out. I'm guessing I don't think I've seen one of these cases yet, but I'm guessing if it was signed out because it's not a carcinoma, it would be just signed out as like, what tissue is it, what was the procedure, and then serous cystadenoma measuring the size and greatest dimension and talk about the margins. But even like, I think the margins here margins are always important. And that brings us to our last case. So this is a 30-year-old female. She presents with vague abdominal symptoms. She has some pain and fullness. And after abdominal imaging, it's found that she has a very large 7-centimeter, well-demarcated, thick-walled, multifocular, I can't pronounce this word for some reason, I'm sorry. Multifocular cystic mass with peripheral calcifications in the head of the pancreas. So as you can see it right here. And there's a little septa right here. It says tail, but I meant to write head of the pancreas. My apologies. And when the surgeon cuts it out and we receive the specimen, we see that this is a unilocular cyst with kind of like a smooth, partially discolored lining kind of located in the tail of the pancreas. So this is the cyst. This is the smooth lining. So we're like, okay, well, let's take a look at what it looks like under the microscope. So we'll go to our case 6, and we'll take a peek at what it looks like. Again, beautiful section. And the reason is because we have normal pancreatic tissue, and we likely have our lesion right over here. Take a look. This is our cyst. This is our cyst right over here. So let's do a quick one pass over the lesion to see what we're working with. And I believe these are some calcifications. Look at that. We got some calcifications over here. It's exactly like we saw on the scan. So, okay, we're seeing, from a low power, some normal pancreatic tissue right there. We're seeing this fibrous stroma. Kind of looking very, very fibrous stroma. Okay. But let's keep looking. Let's not just, zoom in on the areas that we want. We want to see everything. What is this? More like collagenous stroma. Let's take a peek at our normal pancreatic tissue. Looks like normal pancreatic tissue. Looks appropriate. And then after this, let's go take a look at our lesion. Make sure we look at everything on the slide. And what is very interesting, this is a very unique lesion because here is the lumen of the cyst. Here is the cyst lining. Here's the pancreatic stroma. But what's really cool, at least, I don't know, it's not cool, but it's just very unique about this cyst is you could see this area right here. This cyst is lined by an ovarian type of stroma. And that is very unique to this cyst. This is actually diagnostic for what this lesion is. You need to have ovarian stroma lining this tissue. Ovarian stroma is this kind of spindly cells. You can see they're very, not spindly, but they're very wavy. Their nuclei are very wavy. They are kind of spindly, and they're lining this cyst. And the cyst is composed of, again, of like columnar cells with lots of mucin. So let's take a look at all of it. And for this lesion, again, I believe that you would need to look at the epithelial lining to see whether there are any high-grade features present. You want to look at high-grade features. You want to look at low-grade features. So let's take a peek over here. Again, we want to look at the lining. So let's pretend that we're going to sign this case out. Ovarian stroma lined cyst. So far, from this power, the epithelium looks pretty unremarkable. Like it's generally low-grade kind of epithelium from what we saw. I don't see, like, I was looking at here earlier when we were looking at this initially, and I was trying to find whether there was any epithelium present here. I am not seeing any epithelium on these sections, or at least on this part of the section. So really what we have to work with is right over here. So let's take a quick pass again over this area. We're not really seeing any high-grade features. Yeah, it's all mostly low-grade kind of epithelium. And then look at that ovarian stroma. This is very I wish I had a slide pulled up of an ovary that I could show you how similar this looks like to ovarian stroma. But again, we're looking for any kind of high-grade features of the epithelium, and we're not really seeing any here. That's important to note. So, okay, so what could this be? This is a mucinous cystic neoplasm. This is 10% of all pancreatic lesions. And the interesting part here is that this is predominantly in female. This is on a test or on a board exam, if it's a female pancreatic lesion and you see this ovarian kind of dense ovarian stroma, it is a mucinous cystic neoplasm. It has tall columnar epithelium. It's mucin producing. And again, atypia is very important to find in this lesion because it can be high grade or low grade, and invasion can be present in 15% of the cases. The ovarian stroma is required for diagnosis. Prognosis is very, very excellent without invasion, but if invasion is present, the prognosis to 5-year survival drops to 50%. The epithelium has, again, like we saw, very low-grade dysplasia, can consist of flat cuboidal cells, mucinous, or mucinous columnar epithelial cells without any atypia. Here's the cyst lumen. Here's the epithelium. Look at that ovarian stroma right here, hanging out right over here. Okay, we can also see some like papillary or micropapillary architecture and some high-grade cytologic atypia. So look how different these nuclei look like versus these. They're all kind of stacked on top of each other, disrespecting each other's boundaries, and kind of clearing out of their nuclei, which is these are like on a basally oriented. And here is the ovarian type of stroma, very dense, has spindly cells, scant cytoplasm, and uniform long wavy nuclei. So we would sign this case out as like, again, pancreas, partial pancreatectomy, for example, because I think, if I remember correctly, this was in the tail of pancreas. So like a distal pancreatectomy could also be could put distal pancreatectomy over here. And here we could say it's a mucinous cystic neoplasm, low-grade features, measuring so-and-so in various dimensions, margins, and lymph nodes negative, and no definite lymphovascular perineural invasion present. Again, staging for IPMN is... Staging for mucinous cystic neoplasm is similar on IPMN staging. There's a typo over here. And again, we want to know whether the lesion is high-grade or low-grade. If it's a high-grade, it becomes a carcinoma in situ, and we stage it as a carcinoma in situ. And the size of the invasive component is important for staging because that determines the stage, how big the invasive component is. In this case, we don't have an invasive component because this is a low-grade lesion, has low-grade features, so we do not have to stage this from what I understand. So here is the tidbit of trivia. This painting, if you were an art buff, you probably recognize this right away. I found this on Wikipedia, and I thought it was really cool because a lot of the stains that are used in pathology, like hematoxylin, eosin, and multiple others, they are also, or at least at some point in time, or in some point in history, were used, or still are used as clothes dyes for textiles and in painting. So for this one, this is a painting that Van Gogh painted. He's depicted, his field with irises near Arles painting. He incorporated red eosin into the color of the irises depicted at the bottom, right over here. Because eosin fades, the petals have now attained this bluish hue from their original purple coloration. And it's used like a red dye. Eosin is a red dye in inks, and this molecule, especially eosin Y, tends to degrade over time, leaving behind its bromine atoms. So, as you can see, it kind of gets like a little darker brown tinge over time. And yeah, that is select cases in pancreatic pathology. And thank you for listening. And I hope you enjoyed both the pancreatic cases and the tidbits of trivia about art history. Thank you.